Welcome back to The Deep End. I'm your host, Kelley Scott, and I'm glad you found us. We're here for conversations about what matters most. Listening, not to respond, but to understand. Today we're talking about something many of us feel but struggle to name: the relentless speed of healthcare. Appointments measured in minutes, decisions made in crisis. A system that moves so fast that patients, families, and even clinicians can feel like they're being carried somewhere they never chose. I'm welcoming back Dr. Jennifer Clark as my guest today. Jen is my friend, my colleague, and my partner in this work we both love and in which we both wear many hats. Welcome back, friend.
Hello, my friend. How are you?
I'm a little hoarse today, but we'll just ignore that and keep going.
As apropos to the introduction.
Yes, that's right. That's right. And you?
I'm good.
It's been a while since we talked last.
Yes.
Well, I'm glad you're here. Jen's hat today is that of a palliative medicine physician and healthcare delivery scientist.
Mm-hmm.
Do you want to define that for anybody or just leave it out there?
I think it's pretty self-descriptive. I was a chief medical officer of one of our large healthcare systems and quickly had to adopt a hat that understood healthcare at a systemic level. And so there are many, kind of avenues for that. And one of the easiest ways to talk about it is healthcare delivery science or systems consulting and things like that. And it's really looking at, what is the crux of the system? Does it deliver? What does it live upon? What does it breed upon? How does it function? Really what its orientation is toward and to what service.
And that big picture approach is what we're going to dive into today. We're going to talk about how healthcare became a high-speed train, and is there a way to slow it down without derailing care itself?
Mm.
I know this is a conversation that could go a million directions and last many hours. We're going to try to be disciplined and try to follow this arc. We're going to talk about how we got here from a historical perspective, what the speed is doing to people,
mm-hmm.
and how we begin to slow it down practically and morally.
Mm.
So first, let's look at how healthcare got on this high-speed train.
Gosh, I'm just going to start from where, I typically teach from. So I teach several places about, kind of systems design, particularly as it applies to healthcare and kind of particularly human systems. So bottom line, I think probably the most important thing that my hope people would glean from listening to us today is to understand that the U.S. healthcare system particularly is built as an ode to pathology, meaning it is disease-oriented. Mm. Our educational system, the delivery models honor the disease process. The humanness is secondary. And that's not to be bastardized or shamed. That is the system that was established in the 1600s. When modern medicine came into being, it was the separation of church and state. The church got the mind and the spirit, and science got the body. And the thing that people were plagued with in the 1600s, quite literally, were epidemics, famine, and war. And we were doing everything we could to overcome the physical assaults that we had on our bodies that conferred a very young mortality.
We weren't meant to live this long.
No, disease was acute and it was externally driven about, things that we had no control over, really. We didn't even understand the germ theory of disease at the time. And unfortunately, that whole system has remained in place, not only for acute illness, but hasn't kept up with this shift in chronic illness. And arguably, when you look at the healthcare delivery and how it relates to healthcare outcomes, there was a very big shift in 2015. That when you look at the U.S. mortality rates or life expectancy, we took a nosedive. And for the first time in our history, our meaning species histories, we weren't living longer than our predecessors. And so when that happened, a lot of people paused and said, what is going on? Other OECD countries, or basically the westernized world, were continuing along a trajectory that we in the US weren't following. Not only were we not following along the same curve or trajectory, we were flattening out, and then we took a nosedive. And those images are really bothersome. And so there was this deep breath and says, where did this start? And there was indication our mortality or life expectancy curves were flattening out beginning in the 1990s.
Because
there's lots of guesses, but the biggest guess that we now know because of the kind of forward thinking and the putting the pieces of the puzzle together is that we started ignoring the social determinants of health.
I knew that was where you were going. I knew that phrase was going to come in.
Yeah.
So all the things that really contribute the most to our health and well-being that really don't have anything to do with healthcare.
Yeah. Blatantly. I mean, it is hard and fast. Healthcare in its system, in the delivery system that we have, still is really good at the 10% of your health that deals with acute infections, trauma, and, metabolic derangements. We don't really have famine too much anymore, but we have overconsumption, which confers as much of a problem as famine does. And so we're really good at that 10%. A system that was built in the 1600s to deal with those three things, the system is built really good to deal with, particularly in the United States. You have a heart attack, right? We got you. You got an infection? Most of the time, we got you, right? You have a trauma? We got you. Outside of that 10%, 90% of your health is where you live, how you live, and with whom on a day-to-day basis. I have no control over that as a member of said system, right?
Right.
And we keep asking the system to be something it was never built to deal with, which is the social determinants of health. And as a government, we have a thing called the American healthcare paradox, which means we spend the most amount of healthcare dollars per capita in the Western world and have the absolute worst outcomes. Mm-hmm. And the reason being is that for every, kind of statistically, for every $1 in healthcare spend, we only spend 50 cents where our colleagues spend $2. That number's probably shifted a little bit, but generally you get the idea that our values as a society in the United States is bootstrap individualism, as examined by this whole crux around the social determinants of health, the U.S., caregiving crisis that we're in, where we have an aging population of people and no safety net of caregiving for them. And so, so what happens? Well, people are, kind of in a system that is disease-oriented towards acute disease, where 85 to 90% of disease that we're seeing in this system has to do with lifestyle choices that are reflective of a lack of value around the social determinants of health. And so it all comes back to, don't ask a system to do something it was never designed to deal with.
Not a healthcare system at all.
No, it's not a healthcare system.
You refer to it a lot. I hear you say a sick care.
Yeah.
It's a sick care system.
Yeah, it's a disease-based care model, right?
So looking at modern healthcare from that historical perspective.
Yeah.
What is fundamentally different from its original purpose to now?
I mean, there's lots that goes with it. I mean, when you look at the, kind of take that through line, we've talked about in 2015, the moment where we were like, holy smokes, what is going on? We saw the flattening of the curve in the 1990s and all the social kind of governmental policies that changed around healthcare, particularly. And then if you take it one step further back, World War II marked a significant period of time where we moved into theoretically a more peace as a normal part of things versus, kind of the global war kind of experience that we were having. And as a result, more and more people were getting educated because of the GI Bill. When a society undergoes a rapid intellectual growth, also innovation comes with it. And we have this massive growth in medical technology in the last 100 years. I mean, to think about in my 25-year practice, things like CT scans and MRIs. I mean, I remember when the first ones came out. HIV went from a fatal illness to one of a chronic disease. All things like ALS and all of the, all of the vaccinations and all of the chemotherapies and all of these interventions we have now to stave off some of these more chronic, insidious illnesses have all happened in arguably the last 20 to 25 years. I mean, and so we have a society where we're becoming much more educated. We're rapidly developing innovations, and our social fabric is breaking down because we're moving away from being together as a core unit of family. We have a thing called the diaspora of the family, which is, we're all connected virtually now. We're no longer physically.
We're spread out over
so
many different areas.
Right.
So think about this from the human standpoint. What you're describing from this historical lens, I mean, even back into, 1800s, 1900s, when physicians were rounding on horses and going to people's houses and delivering care in people's homes.
Yeah.
That shift from a real relationship-based mode of care to you bring everybody to this one location and multiple people address your issues in the same spot. What's that done to us?
Before I answer that question, I think it's kind of apropos to kind of name how we are sitting in this house right now. Because the original reason for hospitals being built were for nurses who were caring for dying people. Paradoxically. Right? So, we talk about the efficiencies of care. It was how do we bring death into community around the nursing care that was being given?
And a lot of times those were disease oriented.
Yeah, totally.
The TB sanatorium.
Yeah, right. Exactly. So when you take together this technological growth that we've started, kind of arguably back in World War II that is rapidly continuing today, along with the diaspora of the family and the globalization of human life, where we're constantly connected to each other virtually, but not physically. So this diaspora of the physical family. And our ethics haven't kept up really with innovation. And we're starting to see the implications of that with AI particularly. And, you talk about this speed. It kind of in my world, the way I've understood it is technology has really dictated the velocity by which we have to incorporate all this new information, and our ethics have not caught up with it. And so what happens is people get lost in, what it means to be human with a finite, kind of a finite body that is subject to, the diseases that we are always subject to. And now we don't have a caregiving system to support us as we go through the trajectory of our lives.
And that speed, I believe, was meant to improve care.
Yeah, there was never intention to not improve care.
It was not malicious. It didn't just break overnight, but looking at metrics and data and specialization and productivity and everything got optimized
around diseases. Right. The care model that is around disease-based management, not human-based management.
Right. So what evolved was highly developed and technical and quite impressive. But what happens during evolution, you lose.
Yeah.
You lose parts.
You lose the humanity of it, right? And so we keep bastardizing and blaming and shaming and pointing to and aiming at a healthcare system that was never built to address the social determinants of health. There was an assumption that the social part of our lives would be taken care of by this system that we call a community. And that broke down, and the way we spend our our governmental dollars to support the ever changing social fabric of our communities hasn't kept up with the reality of what that looks like, particularly around caregiving of vulnerable populations, whether it be our small children, our school-age children in our educational system, those who have disability, and those who are ill and or aged that require a caregiving network. We don't have that in the United States.
And it's hard for me to think about any of this without, we really miss the human centeredness. And yet at the same time, we've lost some of our individual responsibility. And so, what drove this transition for particularly, I think, in this country, all of us thinking that we didn't necessarily have to eat a healthy diet and exercise if we could just get a pill prescribed for something that went wrong. That
Yeah.
we don't have to manage our blood pressure if we can take a medication to do that for us. And how did we slide into that?
Gosh, a great question. I don't think there's an easy answer to that. I think it's if you look at us, kind of one of us, let's just take an N of one, right? We are stuck in this chasm, this vast chasm between the healthcare industry that's driven by our governmental payer systems. So the Centers for Medicare and Medicaid really dictate the insurance system that then the payers, kind of follow. So we have the healthcare industry driven by government, which includes the insurance company and the pharmacological industry, you know. So on one side, we have this, sheer rock wall that we're having to deal with. And then on the other side, what's happened in the United States particularly, but you also see it kind of globally, is this thing called the wellness industry that is really driven by entertainment and food, particularly. And as humans, our nervous systems are hardwired at the very rudimentary level for pleasure and pain. And we move towards pleasure and move away from pain. I mean, that's just basic survival. And when you put us in an environment where there's hyper palatable, highly rewarding food and other sensory experiences, everything that we watch, everything that we listen to, all of the entertainment that's going on, our nervous systems get hijacked on dopamine. And as a result, we get into these highly overconsumptive, habituated behaviors, whether it be eating or consuming other sensory experiences otherwise. And it puts us in a near state of addiction and many people into addiction, trying to quell the rapid cycling of the pleasure pain balance. And there's plenty of data out there to talk about that now. And so we have an environment that puts us in this state of chase, constantly chasing pleasure. And as a result, we overconsume in everything, including food, right? Including drugs, including fill in the blank, right? We've drugified everything. And as a result, these chronic lifestyle diseases of overuse of the human system. I mean, name a disease that's a chronic illness, all starts with C: chronic liver disease, chronic lung disease, just chronic congestive heart failure, cirrhosis, cognitive disorder, all the things, right? And so it's lifestyle choices. And the reason why is we are a nervous system that is not built for excessive overabundance.
But that's all the healthcare system feels like it is. That's all our world feels like it is.
Exactly. But in the United States, we have lost this, the basic human needs of safety and connection, right? Food, water, shelter, sleep, and a place to belong, to lay my head down at night, know that I'm okay and that there are a group of people that will care for me if I can't care for myself. Those are fundamental needs. I mean, Maslow named them, in the 1940s. They haven't changed.
And I think part of the whole historical transition included this transition from care of each other as part of our basic family responsibility to relinquishing responsibility and control of that care to a professional.
Yeah. I mean, we have overvalued our monetary worth, meaning finances and having, power associated with money, this belief that money can buy you everything.
And the sense that I'm not equipped to do it. I'm not equipped to care for my sick or dying person. I don't know how to do it. It's outside my skill set. People just have lost a sense of ownership of, I think, basic caregiving skills that existed for eons.
Yeah, I mean, to your point, we have a disease system that's looking for disease, and we've offloaded that. We pay that system a lot of money to take care of this disease, right? And so as a result, everything moved to that centralized disease-based system, care, caregivers, expertise, everything moved out of the community, right? General knowledge, right? Basic understanding of how the human body works and when to worry and when not to worry, and all of that kind of stuff. We've offloaded that to this island that we call healthcare that really sits outside of the fabric of our communities. And our fabric of our communities is now loosened so significantly that we're losing each other in that. And so it's broken on both sides of the fence, right? We don't have the resources or the values within our social fabric, right, to support the crumbling concepts of what happens in a disease-based model of care. So we have two systems that are leaving us vastly in a gap of no win.
So let's talk about the cost of this transition, this complication of every area of the speed and the urgency at which everything moves anymore. What's that emotional and human toll? What happens to people that have to get into the healthcare system and it's moving faster than they understand?
Yeah. I mean, I think to your point, if you take that whole kind of concept of being able to discern when something is emergent, urgent, or it's, okay, and can be waited on, give it some time and give it some space, give it some care and things will be fine. Everything is now urgent and emergent. And that's a consequence of this acute disease model that the system is primarily built upon, right?
But that's how you get a response.
Exactly.
You can't go for something and get attention and get help and get,
unless your arm's falling off.
Exactly.
Right? Exactly. And so everybody makes the smallest of things a crisis. And in the process of that, we lost the skill of discernment.
Or they truly are a crisis because we have no resources to fund whatever the need we have up front, right, or early on, or when it could have been more preventable.
Right. We're like, that's not your problem. Our problem's when you're in crisis.
So you have to get to crisis before anybody gets care.
Right. Mm-hmm.
Yeah.
But yet we don't support people upstream, right? We don't give them the caregiving resources to stay at home. We're starting to kind of try and figure that out. There's things like hospital at home now, but we haven't expanded, basic caregiving, lay caregiving, community care. I mean, Clare House is a perfect example of one population of people where we have solved for that issue, that basically we provide the social determinants of health around a population of people that happen to be dying and their family members. And oh, hey, we figured out, by the way, that death belongs in community and not in the hallowed halls of a dark hallway in a hospital, right?
And we've remembered that it doesn't have to be done by professionals.
Right. It was done by lay people,
right,
in most of human life.
Right.
It's only in the last 100 years did we medicalize it and institutionalize it. And that's the case with a lot of things, right? That end of life is one of the many circumstances where people do better when they're closer to home with people that love them, right?
Right.
And so the people that love them are a constellation of people now. They're not necessarily quote unquote blood relatives, the family that is the traditional model. We are creating families of choice that come from all sorts of different places. People are seeking that deep, deep connection because they understand that that's a significant part of the fabric of our life in the United States that has fallen apart, as evidenced by all the trauma that we're starting to see across the globe with regards to, you know, all the policy and the government changes that are happening right now, and the injury and harm that many, many people are sustaining.
So accepting that we live in a system, we live with a system that is highly interconnected and disconnected at the same time, very complicated, um, very challenging to navigate, and move so fast that you hardly have time to learn
Right.
how to best move through it. What are families losing when decisions are forced under a sense of urgency because of the speed of what might be happening, say, in a sudden accident or a sudden illness, an acute exacerbation of an existing illness, whether it's something you've been dealing with that's suddenly gotten worse or something that's brand new? You find yourself in the midst of this system that's moving so quickly all around you, and you're lost.
Yeah, I mean, I think it simply boils down to that you are responsible for figuring it all out. There is no guidance, right? And oh, hey, by the way, you need to foot the bill, right? So insurance pays for that acute process. So as long as you're in that acute process, meaning in the hospital system and maybe in and around the aftercare for a little bit, most insurances will pay for that. Well, how many people don't have insurance, right? So people are walking around with no insurance. So there's a lot of uninsured people. The people that are insured, it's so spotty about what's covered and what isn't covered that most people don't have any idea what 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 and how to access the care that is actually covered. And as a consequence, they go into the hospital and all of a sudden they have a $50,000 or worse bill because their insurance that they've been paying on actually doesn't cover certain things. And because it's, the fine print of those insurance policies are so dense and hard to understand. I'm a physician and I don't understand that 90% of the time that, people, no wonder people are becoming destitute over a medical crisis. I mean, the statistics are horrible in the United States. They change so rapidly. I'd hate to quote
It's
like
one of the top reasons for bankruptcy.
bankruptcy
In this country is medical debt.
is medical debt, right? And so, so there's all of that piece of things is that people, again, we try to be preventive to some extent around our healthcare. We always, because the disease-based model has told us that it's about rescue and recovery. I'm either healthy or I'm not, right? Health is an experience and not a state. We've tried to change that definition for a really long time. But the working definition of health is the absence of disease. So if you don't have a nameable disease,
You're healthy?
you're healthy. You and I both, I mean, you're laughing right now.
Right.
Right? I mean, and so that's the problem. And so people are kind of like, well, I feel, meh, meh. Again, discernment is a problem. And then all of a sudden it's a crisis. And if that person who has the crisis plays a key role in a system of people, there is no safety nets to support them. So if you have a breadwinner in the family that all of a sudden collapses due to a heart attack or has a brand new cancer diagnosis or has a stroke, right? And they're in the hospital and will not recover or minimally recover to their previous state of health, that whole family unit goes under because the finances that support that family oftentimes aren't then fortified with, either governmental support, community support, and or organizational support to reinforce a very weak societal fabric that lives with a, kind of disease-based model of health.
And I'm going to go again to the individual human experience, and I want to talk about this for a minute from a viewpoint that I've learned from you that I still the imagery of it is so powerful to me, and that is human brain development and how it reacts to stimuli. And you've talked about this before, but I think that in times of crisis, in times of overwhelming stress, when your nervous system is
Mhm.
placed into a bigger system that feels like it's coming at you from all angles, you're going to probably have a pretty reptilian response
Oh,
to
yeah,
that.
totally. Yeah.
What does that look like?
So, kind of nervous system 101. As humans, we have, at a very basic level, three-part brain. We have a reptilian brain that then kind of got a mammalian brain stuck on top of it. And then there's a human brain where our cognition and our ability to think, our IQ, our ability to problem solve and imagine and plan, we call that executive functioning. It sits right behind your forehead, above your eyes. That's the adult human brain. And when it is exposed to stress, we move down that ladder. We go from a human brain to mammalian brain to reptilian brain. So you have to make a decision. Am I going to be a human today? Am I going to be a dog or a lizard? Right. And when we are exposed to stress and we kick into our one of two, kind of biological stress responses, everybody seems to know fight or flight. The other one people don't understand, but as soon as I talk about it, people are like, oh yeah, I do that. Is a thing called dissociation where
I'm leaving this.
I'm out, right? Where it's like you just kind of check out of the situation, right? You kind of leave your body. Some people quite literally do, right? And so either way, you're in a stress response, fight or flight or dissociation. And in that, we know your IQ and your ability to make decisions, to be present and understand decisions having implications on your future life goes down drastically. Drastically. Our IQ drops by tens, if not 20s of points, the further down that continuum of stress response that we go. So you can imagine, right? It's like jumping from the frying pan into the fire, right?
So when someone comes at you in an ICU waiting room
Yeah.
and wants a decision,
Right.
what are you supposed to do?
Right. And so this is why we plan ahead. This is why we have these conversations upstream. In a perfect world, we have this rescue and recovery system that works really, really well. We also need a prevention and promotion system. And we also, God forbid, we build a system around flow and flourishing and optimizing a human life. And arguably, the prevention and promotion and the flow and flourishing systems are outside, though talk to the rescue and recovery system, but those are the social determinants of health, right? That are built by communities of people and the government that supports said communities. And so it starts small, right? And so, when families talk to me about this and they get really overwhelmed, I'm sure many of you guys that are listening right now are totally like overwhelmed with this. And I always go back to the basics. Are you safe? And who are your people? Don't focus if those things are not met right now, that's where your focus needs to be. Who are your people? And where are you laying your head down? Where are you getting your food? How are you taking care of your body? Right? And only until then can we move into those more growth-like needs like self-esteem and exploration and intimacy and purpose, So many people are walking around with unmet basic needs. So start there. Do I feel safe? And do I have a group of people that care for me?
Ultimately, that's going to have a lot more impact on your life than what your doctor's going to tell
Totally. 90% of your health is answered in those two questions.
How does all this affect clinicians, do you think?
Oh,
To be in this system, to be living at this speed, if you're self-aware enough to know what you're describing as being, I mean, it's not futile, but it's only 10%. That's not the huge impact that I think decades ago, a shot of penicillin that would be life-saving and changing, and that's it. We've saved somebody, that sense. And anymore, I see that less and less. unless you're in those really dramatic areas of rescue.
I totally agree. As I counsel students interested in entering, the helping professions into the healthcare system, I'm like, be informed, have informed consent about what you're getting into. Know that you're entering into a system that is foremost interested in disease-based model of care. So if you're not interested in diseases, this is not for you, right? Um, and being open to physicianhood or practicing nursing or social work or what have you, being in an innovative model of care. I mean, you're a perfect example of that, right? I haven't practiced in the traditional healthcare system since 2018. I mean, am I still at a bedside? Yes, but in a way that allows us to be in community and in a lay caregiving environment.
And it was frustration
Yeah.
and a not feeling like I was making a significant impact that drove me out of the system.
Right.
And I think it did you as well. That
Yeah.
I think we both felt like we could be much more effective outside the system and working outside than we could be inside.
I found, so just to be real frank, and I think a lot of people know this about me, and, I work with people across the globe in the concepts of moral injury that many of us sustained during the pandemic, but many of us had sustained already. And it's related, but not interchangeable concept of burnout, right? So moral injury is exactly what you're talking about, is that I went into healthcare because I wanted to help people. And the injury that it takes to work within that system when I have to honor a disease-based model of care and my entire livelihood is tied to ICD-10 codes that name diseases, right? Where the deep connection and value that I have in caregiving is actually the relational aspects of my bedside practice. I mean, I'm a palliative care physician. I mean, communication's like my scalpel, right? And it took years for us to even be somewhat compensated for some of that, but it doesn't even scratch the surface of time and energy and skill that is required to be at a bedside of someone who is in serious illness and is dying, particularly in our system, right? And so it became, how do we change that narrative? How do we bridge the gap? And so that's where I've spent, last 10 years of my career particularly is having conversations like this that kind of name the water of what's the reality of our healthcare system and our, kind of denigrated fabric of our social dynamics and how those two things are contributing to each other, and looking at innovative models of care that fortify our social fabric, recognize where the healthcare system begins and ends, and innovating to the gap between those two things.
We can be so good at treating disease,
Mm-hmm.
not so good at just accompanying people, at being with,
Yeah, we
at
love
being
I mean,
present.
you've got to decide you like people. And that's the problem, is that you got to be really interested in human beings.
Right.
And talk about velocity. I mean, the whole experience of the virtual world. I mean, I feel really lucky to have been in a world where there wasn't the technological,
Oh, yeah.
and the
Oh, yeah.
connection that exists. I mean, I feel fortunate, privileged, somewhat befuddled, trying to articulate that to my own children and the generations that came behind us.
Any dive at all into generational studies is so, it provides so much insight when you look at where a certain generational group started and what they've gone through over their 30, 40, 50 years, and the changes in technology that happened during that time. Just simply the technology itself, that impact it's almost immeasurable.
Yeah, and kind of back to that wellness industry kind of quagmire that we're in, and we're in an industry, kind of are in an environment that's so highly rewarded and gamified because of the kind of virtual reality that is created on our phones, particularly. um you have to make a conscious effort to actually get in the dirtiness of being with humans, like that.
Yeah.
It's messy.
Yeah.
And it's not easy. And so, how do we pull that so needed decent human connection that, kind of that is supported maybe by virtual stuff, but isn't supplanted by it. And I think we're starting to see the younger generations figuring that out, that they're like, no, can we put our phones down? I mean, like there's this natural tendency that, some of us that kind of had to, like, whether they're, kind of late baby boom, early Gen X, that are totally attached to their phones because we're so dopamine addicted, that, our kids and the kids younger than them are really starting to kind of have this regulatory experience, that they're putting those down and kind of connecting.
The pendulum is swinging back.
Yep.
So that moves us into our final arc of how we actually get off the train.
Yeah.
And is slowing down possible inside this healthcare system?
I don't think the healthcare system is going to slow down, and we have to come to a realization where the slowing down occurs is in the social side of things, right? Because
so how do we do that? How do we opt out, interrupt, redefine when we're sick, when we're in need, when we're in a situation of crisis? What are some tools? What are some skills?
Yeah, I mean, back to the basics, right? Do you have basic safety? What are your resources, right? Food, water, shelter, sleep takes on a whole different layer of safety in our current modern environment, right? So, what are your economics around care and your own health? That is not gym memberships, right? Everyone's like, well, I belong to a gym. It's like, do you go? Right?
I donate every gym. One of my favorite charities, apparently.
So what are the economics? What are the economics that you're willing to contribute to your health? And this is about food for fuel, adequate, really good water, which is becoming a bit of a crisis, right? Are you getting adequate enough sleep? Like, so the way I talk about it, what is your home environment like? Are you really spending time creating space as a safety net to support your health, right? And then the second part of that is, if you have a house, you also need a home. So who are your people, right? That doesn't mean it needs to be your kids. It can be, but you need to have a conversation with your kids, right? Or your parents, or your spouse, or your friends, or your siblings, whomever you believe that if you were to hit the fan tomorrow would come to your aid. You need to talk to them about that belief and ask permission. Because what happens, there is nothing more painful for me at 3:00 in the morning to pick up a phone, call an identified healthcare proxy of a patient who can't speak for themselves, facing their own mortality, and have that healthcare proxy say, they named me what? I've never talked to them about
realize
it. I have no
paperwork.
I have no idea. And that person being burdened not only with making massive decisions, but likely that person is also going to have to deal with the consequential economic, social, emotional, physical, and psychological care of that person should they survive this acute event. And we have no infrastructure for that. We leave it to people to do that on their own. And so being honest about our system and how it's built, and, debunking this myth that somehow because I pay insurance, I've got all these resources, that's not true. And so you need to do a real quick assessment of what's my house and what's my home right now, and fortify that towards the economics of your own health, and understanding that that's finite, and what that looks like when, not if, but when the time comes, you're going to need care.
And you know what comes to my mind listening to you is something that I've learned just recently again, and that is that when we're faced with a symptom or a crisis in our health, that is a wake-up call. That is something that's saying, hello, I need your attention right now, and that you can't just roll that symptom or that event into your life and keep going unchanged. that you have to stop and say, what's out of balance here?
Mm-hmm.
Am I overwhelmed? Am I not getting enough sleep? Am I
Right.
lonely? Am I stressed? Am I too stressed at work? And begin to really listen to those symptoms, those events, those wake up calls to change behaviors that are driving us further into chaos
Right.
rather than pulling back and listening to those. Something's trying to get our attention.
Yeah.
And we don't often honor that.
I mean, it's simple. I mean, one of the things I always talk about, I'm like, before you make any decision, you need to halt. Am I hungry? Am I apathetic, angry, or anxious? Am I lonely, or am I tired? If you have a major decision to make, try not to do it under duress.
That's a great acronym. Say the words again.
I can't remember her origin. The first place I read it was in Jill Bolte Taylor. She's a neuroscientist that talks about this. Her stroke of insight. She was a neuroscientist that had a stroke. Pretty profound TED talk if you haven't listened to it. But then she wrote a book called Whole Brain Living, and she talks about this HALT method, HALT, which is, learning to pause. I actually think that's the biggest act of an adult human, as someone who can pause in the midst of a chaotic situation and say, okay, check in with your body. Am I hungry? Am I apathetic, angry, or anxious? Right? Because those are our primary kind of emotive loads, right? I don't feel anything. I feel everything, or I'm pissed about it. Right?
Yeah.
And so hungry, anxious, apathetic, angry. So HAL, lonely. People talk about loneliness. The reason why loneliness is so painful, it's the connective equivalent to hunger. It's the need for connection going unmet. It's loneliness, right? Sometimes it takes on the shame of, the form of shame, because it's like, I don't feel worthy enough of having a relationship. Sadly, I see that a lot.
No one values my presence.
Yeah, I don't matter, right? Mattering. I need to know, who do I matter to, right? If I were sick tomorrow, who would care? Right? So HALT. T is tired, right? Most of us are sleep deprived.
It's pretty basic.
Right.
So what a great tool to use when you're faced with a hard decision, to be able to say to someone, I need time.
Yeah.
You've absorbed whatever information you can absorb. Maybe you've been quick enough to pull out your phone and turn on your voice recorder and say,
Yeah.
do you mind if I record this so I can listen to it again in 5 minutes when I've forgotten it? And then you say, I can't give you an answer right now. I need a minute. And you find a place and you walk through that HALT acronym. And if you need to get some lunch before you make this decision, or maybe you need to sleep on it and go home and take care of yourself before you come back and choose. I don't think we feel like we have time to do that.
Basic needs. If you can't get your basic needs met, how do you think you're going to make higher needs met? I mean, it just doesn't work, right? And if you're resourced enough, extend the compassionate act of helping someone else meet their food, water, shelter, sleep,
And that's oftentimes not the way decision making is approached in the hospital. No. Somebody comes at you, literally, with a barrage of information, and they want an answer and expect, okay, we can do this, or we can do this. Here are the expectations of that. Here are the consequences of that. Which one do you want?
I mean, I'm a hospice and palliative medicine physician. My entire subspecialty was built to address this issue. We had to develop a whole new practice. And unfortunately, the practice of palliative medicine, which is the one that's in the hospital in the acute crisis, is being sucked into this, the vortex of episodic, care. And so it's really, really hard. And, families are better off really focusing their economic dollars and their value on the prevention and promotion of health, peace, and God forbid, flow and flourishing. I mean, I'd be happy if we got to that part, right? So that only when you absolutely need it do you tap into the rule of rescue, right? And the rescue and recovery model of modern-based, disease-modeled healthcare that we have in the United States. And don't ask it to be anything more than that.
What models of care have you seen that resist unnecessary speed. I think this.
Ours. I was like,
Ours.
I'm like, we're
Model.
sitting in it right now. I mean, models like this where there is deep care and wonder around a specific population of people. We see some of it in, innovative models of childcare. We've got several of them here in Tulsa where we find a population of people that require caregiving, particularly, and caregiving that extends far beyond the healthcare system, and standing up resources around that. And so, yeah, we don't have a whole lot of examples, but there's small pockets of them. And I think if we learn to translate things like Clare House, right, across other populations and say, use human-centered design, right? What is the need that requires innovation around versus having all these innovations looking for a problem, right? We got plenty of problems, right? Let's go to where the humanness is, and how do we really fortify that? And again, building these models where, Clare House, when it first started, was a prevention and promotion kind of thing. Let's avoid going into the healthcare system. And arguably, we've continued that model, but we've also moved into this flow and flourishing thing where people are actually optimizing their lives as a result of the experience of being in a system that says, oh, this is what humanity looks like. This is what good caregiving looks like.
Because it's an extension of the care community.
Family.
It is not just about the person dying in the bed. It is about all those that are affected by that experience as well, and what they can learn from it, take from it, and move into more growth in their lives.
Yeah.
And I don't think there's any real areas of healthcare that have that extension of the caring focus beyond the sick person.
Yeah.
It's really...
It's the disease, right? Right. It's disease based. Everything, all the resources are around what's the name of your disease and to what extent and level do you have of that said disease. We're starting to see, food as medicine movements. If you look at the basic need stuff, right? Food, water, shelter, sleep. So shelter, obviously our unsheltered population is getting a lot of attention. Our food supply is starting to get a lot of attention. My question is this shelter piece, what is the caregiving network that sits behind an individual?
Yeah, and a new model that I've learned about recently that I love is care farming.
Yeah.
That whole idea that you build community around, whether it's an elder in need or a special needs individual with physical challenges, but that you build a care community that is based in nature, and as a group, you're working not only to care for each other's physical, social, emotional needs, but you're caring for the earth, you're growing your foods, you're doing all of these things in one system together.
Yeah, it's, we talk about that pendulum. That's the swing towards that, right? Is being in small communities that are closer and closer to the ground and the trees and things like that. And we're starting to see more and more of that pop up.
There's hope in that. There's hope there.
You and I live and breathe hope every day in Claris. We know that when you pay attention to a certain population of people with an intent of human care, magic happens.
So as clinicians, even in small ways, looking to reintroduce humanity.
Yeah.
Within the system, not necessarily those that are lucky enough to step outside of it, but for those that are, and arguably we need so many providers within the system working on that. But how do they reintroduce humanity?
That's so crazy. I actually work with a group of clinicians that are at the forefront of this, right? Really creating a communication tool, if you will, that names this disease-based model of care. It's pretty interesting when I get into a group of clinicians and kind of name this whole thing, that their moral injury is revealed, that they are like, oh, that's why I feel this way, right? Something seems so simple, right? You and I were just talking about that. It's like, it's a disease-based model of care. And we keep asking it to be a health-based model of care, and it's not built for that. And so that's, once you hit understand what the rub is, what the pain is, what the tension is that has to be overcome, then it's just one-on-one conversations, whether it's one to patient, one to colleague, one to a family member, that they can then say, I know you came in here and everything we're talking about is cancer, but what matters most to you, right? And being able to build an agenda that's shared jointly, that's focused on what matters most to you and your family, totally flips the paradigm, right? Because what happens when you focus on, hey, I know you've got cancer. Here are the medically valid options, but I need to understand how that fits within your life. And we find more and more people electing less aggressive care if we just are honest about what that looks like. I can't tell you how many times you and I have had conversations with people in our house that say, God, where were you like 10 years ago? If someone had told me this, blah, 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 blah. And so really in the system, we're starting to see people like us going into the system as extensions of the community saying, just because we can doesn't mean we should. And we're giving you permission to have those conversations with us.
And that same question is to be asked at home.
Totally.
As well. That same question, you don't wait for your clinician to ask you what matters most. You ask each other
right.
what matters
that
most.
The abdication of health has always befuddled me. Like, and I think it has to do with economics, that we spend so much money on insurance and the, pill for every ill kind of thing, that there is no paying attention. We lost that discernment piece of things. And so as a result, people aren't having these conversations because it's such a foreign concept. And so because we're having more and more people, I think, if there's a silver lining in the pandemic, I think some of that is that people were woken up to how lost we are as a society around caregiving. And so really, kind of figuring out, okay, I got sick during the, and look what happened. Thank God I recovered. But what happens if I get really sick, or my husband or my spouse or my child or someone that's important to me or whatever? And it really gave people the ability to imagine what that might be like in the future. And so really bringing that narrative back into the fabric of our community versus it being isolated out on an island that we call a healthcare system, people get to see the reality of what it means to provide care to someone who's ill.
And to pump the brakes at every opportunity.
Halt.
Go through your checklist. Ask yourself what matters most. Ask your person what matters most. That opportunity is that. I mean, it's a daily discipline. It could
totally
it could be a daily discipline, maybe for some people, but that slowing down doesn't mean that we're doing less or we're providing less care. It just means we're doing it better. We're providing better care, desired care that's moving in the right direction, not run away on some course that we didn't choose because we didn't have the opportunity. It happened to us so quickly.
Yeah, it's funny when you have a very clear what matters most to me, it actually makes care much more efficient.
Oh, yeah.
Right?
Yeah.
Because otherwise you're on this merry-go-round, right? And when you pause, when you halt and kind of say, okay, wait, hold on a second, you get really clear and things become very efficient, and then the system organizes itself, right? Otherwise, it's going to be focused on the disease. But when you halt and ask it to focus on what matters most to you, most of the time it's your humanness, then the system realigns to get you out of said system, or direct the system in such a way that says, oh, okay, if that's the case, then let's go this way.
And I think that's really practical to think about as we age and our bodies start to change and do things that, we don't like and we don't enjoy, and we start losing some of the function that we had before. And you could test and treat for any number of things with every passing year. And I've been in that situation where I've been to the doctor and there are 5 things they want to look at all at the same time. And I've been able to say, you know what? I'm number one, I can't deal with 5 things at the same time.
Yeah.
And I'm going to pick the thing that's affecting me the most. And for me personally, I'll share with you one of the things that it was that I wasn't sleeping well. It was a lack of sleep. So why? Why is that happening? Why can I not go to sleep and stay asleep? And dealing with that one issue and choosing, I had 4 other things I could have explored,
Right.
but I couldn't deal with all 5 of them at the same time. They didn't really matter that much. But the thing that was going to make the biggest difference was improving my sleep.
Right.
So again, pumping the brakes, slowing down and thinking.
But that discernment's really, that skill of discernment's really important. And the question of what matters most to me right now is a way to do that.
And the other thing is to not abdicate responsibility to a stranger, albeit a well-educated, highly skilled stranger that doesn't know you.
Right.
And for what I hear on a regular basis in end-of-life care as a hospice nurse is, I will say, what do you understand about what's happening to you?
Right.
Well, I don't really understand. I just trust the doctor's going to do the right thing.
Yep.
Well, how now do they know what the right thing is for you if they don't know you or what matters most to you?
And that's not to shame physicians or decision makers at all. That's the system that they were trained in and educated to, that the consumer fortified.
Right. And when that burden is placed on a provider, they're going to move as quickly as they can to do what they think is best because this person's not speaking up.
Right.
So they're going to do what's best so that they can close this conversation and move on to the next one.
And so just because we happen to be within the system, unfortunately, particularly as physicians, I feel like because we are the face of said system to people, we get burdened with the unnecessary injury. Right? Somehow we're to blame. Right? And
then when people are mad at the end because they lost all this precious time, and they're mad at their physician because they didn't tell them enough, but they didn't ask any questions either.
Right.
There's blame to go all around.
Right.
Halt. Stop. Pump the brakes.
Ask what matters most.
Oh, Jennifer. Okay, I'm going to ask you one more question. When you imagine a healthcare system that truly serves people, what feels most different from what we have now?
We unburdened the healthcare system of asking it to be something that it's not. I mean,
that's pretty simple.
It's really simple to me that, rescue and recovery is important. That 10% of healthcare is important, as most of our technology has shown. I mean, as you said, penicillin changed the face of infectious disease, right? And so the rule of rescue is important. We have to have that system, but it shouldn't be the primary system. It should be way, way, way downstream, right? And that we build infrastructure in the other 90% of where health actually happens. It's where we live, how we live, and with whom on a day-to-day basis. And if that's going to be left to the individual, it needs to start with you right now, right? What matters most to you? Food, water, shelter, sleep, and who's going to take care of you and who are you going to care for every day, day in and day out.
Thank you, Jim, for your wisdom, your leadership.
Thanks.
Your humanity.
All of it reciprocal to you too, my friend.
As we end this conversation, I'm just struck by how rarely we're invited to slow down, especially in the moments that matter most. Healthcare asks us to move quickly, decide faster, do more, but maybe what people need in serious illness isn't speed at all. It's space, it's presence, it's somebody willing to pull the emergency brake long enough to ask, hold on, what matters to you right now? Healing doesn't always come from doing more. Sometimes it comes from finally being seen. Until next time.